Type of hysteroscope. What size and angle of hysteroscope should be used in the outpatient setting? Miniature hysteroscopes 2.7 mm with a 3 to 3.5 mm sheath should be used for diagnostic outpatient hysteroscopy as they significantly reduce the discomfort experienced by the women. There is insufficient evidence to recommend 0-degree or 4-oblique optical lenses, for example, 12 degrees, 25 degrees, or 30 degrees offset lenses for routine outpatient hysteroscopy. Choice of hysteroscope should be left to the discretion of the operator. Offset lenses offer a wider field of view, a property that can be advantageous in visualizing the corneal recesses and tubal ossia within the uterine cavity with minimal external movement of the hysteroscope. 4-oblique lenses facilitate a visualization of ancillary instrumentation and so are advantageous for operative hysteroscopy. However, 0-degree hysteroscopes are more intuitive, facilitating entry into the uterine cavity through the cervical canal, which may reduce the need for cervical dilatation as well as minimizing discomfort and uterine trauma. Should rigid or flexible hysteroscopes be used routinely in the outpatient setting? Flexible hysteroscopes are associated with less pain during outpatient hysteroscopy compared with rigid hysteroscopes. However, rigid hysteroscopes may provide better images, fewer failed procedures, quicker examination time, and reduced cost. Thus, there is insufficient evidence to recommend preferential use of rigid or flexible hysteroscopes for diagnostic outpatient procedures. Choice of hysteroscope should be left to the discretion of the operator. Distension medium. Which uterine distension medium should be used during outpatient hysteroscopy? For routine outpatient hysteroscopy, the choice of distension medium between carbon dioxide and normal saline should be left to the discretion of the operator, as neither is superior in reducing pain, although uterine distension with normal saline appears to reduce the incidence of vasovagal episodes. Uterine distension with normal saline allows improved image quality and allows outpatient diagnostic hysteroscopy to be completed more quickly compared with carbon dioxide. Operative outpatient hysteroscopy using bipolar electrosurgery requires the use of normal saline to act as both the distension and conducting medium. Thus, the type of distension medium affect pain experience during outpatient hysteroscopy. The meta-analysis showed there to be no significant difference between the pain experience with the use of carbon dioxide versus normal saline for outpatient hysteroscopy. Uterine distension pressures need to be sufficient to allow systematic inspection of the entire uterine cavity. However, care is needed to ensure that pressures are minimized to avoid overdistension of the uterus and consequent pain. Which distension medium produces the best image quality during outpatient hysteroscopy? Normal saline produces lavage of the cavity and so washes away any blood or mucus which otherwise might obscure the view. Carbon dioxide may produce bubbles and bleeding, leading to unsatisfactory view. Which distension medium should be used for operative procedures? Normal saline should be used as a distension medium when bipolar intrauterine equipment is used for hysteroscopic surgery. Thus, it is more practical to perform diagnostic procedures with normal saline in units offering simultaneous diagnosis and treatment, as this avoids having to swap distension media should operative procedures need to be carried out. Hysteroscopic sterilization requires fluid distension medium The choice of normal saline or glycine depends upon the specific technology adopted. Local anesthesia and cervical dilatation. Should routine dilatation of the cervical canal be used before insertion of the hysteroscope in an outpatient setting? Blind cervical dilatation to facilitate insertion of the miniature outpatient hysteroscope is unnecessary in the majority of procedures. Routine cervical dilatation is associated with pain, vasovagal reactions, and uterine trauma and should be avoided. Cervical dilatation generally requires administration of local cervical anesthesia. Standard protocols regarding the type, maximum dosage, and route of administration of anesthesia should be developed and implemented to help both recognize and prevent rare but potentially serious adverse effects resulting from systemic vascular absorption. Blind dilatation of the cervix to instrument the uterine cavity is commonly performed under general anesthesia and is associated with cervical and uterine trauma. In addition, in the conscious women, dilatation of the cervix causes pain and discomfort and generally requires the use of local anesthesia. Should topical local anesthetic be administered before outpatient hysteroscopy? Instillation of local anesthetic into the cervical canal does not reduce pain during diagnostic outpatient hysteroscopy, but may reduce the incidence of vasovagal reactions. Topical application of local anesthetic to the ectocervix should be considered where application of a cervical tenaculum is necessary. Should injectable local anesthetic be administered to the cervix and/or paracervix before outpatient hysteroscopy? Application of local anesthetic into or around the cervix is associated with a reduction of the pain experienced during outpatient diagnostic hysteroscopy. However, it is unclear how clinically significant this reduction in pain is. Consideration should be given to the routine administration of intracervical or paracervical local anesthetic, particularly in postmenopausal women. Miniaturization of hysteroscopes and increasing use of vaginoscopic technique may diminish any advantage of intracervical or paracervical anesthesia. Routine administration of intracervical or paracervical local anesthetic should be used where larger diameter hysteroscopes are being employed with an outer diameter greater than 5 mm and where the need for cervical dilatation is anticipated, for example, cervical stenosis. Routine administration of intracervical or paracervical local anesthetic is not indicated to reduce the incidence of vasovagal reactions.